For patients with Barrett's esophagus containing high-grade dysplasia or mucosal cancer, endoscopic therapy is considered the treatment of choice. Endoscopic resection is performed to remove focal lesions in Barrett's esophagus. Histological evaluation of the endoscopic resection specimen allows for optimal patient selection. Patients with high-grade dysplasia or early cancer limited to the mucosa are eligible for endoscopic treatment, while patients with carcinoma invading deep in the submucosa or beyond are referred for surgical esophagectomy. After focal endoscopic resection, the remaining Barrett's esophagus is still at risk for malignant transformation. Therefore, it is advisable to completely eradicate all Barrett's epithelium once focal early neoplasia has developed. The combined approach of focal endoscopic resection, followed by stepwise circumferential and focal radiofrequency ablation of the remaining flat Barrett's esophagus, has been shown to be safe and effective for patients with high-grade dysplasia and or early cancer in Barrett's esophagus, with rates of complete response for early neoplasia and complete response for intestinal metaplasia of 81% to 100%. Balloon-based circumferential radiofrequency ablation is the preferred primary radiofrequency ablation modality after endoscopic resection, since it allows for circumferential ablation of the whole longitudinal extent of the Barrett's esophagus. However, superficial lacerations at the level of the endoscopic resection scar have been observed during circumferential radiofrequency ablation in patients who had undergone a more extensive endoscopic resection. Esophageal scarring and narrowing after a more extensive endoscopic resection may result in non-uniform electrode contact and superficial laceration. Recent studies have therefore restricted the maximum extent of endoscopic resection prior to radiofrequency ablation to less than 50% of the circumference and less than 2 cm longitudinally. Nevertheless, in some patients, a larger area has to be resected for removal of all visible lesions. Ideally, endoscopic resection and radiofrequency ablation should be performed in a single session prior to the development of scar tissue during the healing process. However, when radiofrequency ablation is performed immediately after endoscopic resection, the resection wound, which is as deep as the submucosal layer, will be ablated, which may hold a risk for severe stenosis or even perforation. In a tertiary referral center for patients with early neoplasia of the upper gastrointestinal tract, Vilsteren et al. Assessed the feasibility of performing circumferential radiofrequency ablation immediately followed by endoscopic resection in the same treatment session in patients with Barrett's esophagus containing high-grade dysplasia and or early cancer. They hypothesized that single-session circumferential radiofrequency ablation of the whole Barrett's esophagus, including visible abnormalities, followed by endoscopic resection of the ablated yet still visible lesion, might preserve the diagnostic and therapeutic purpose of endoscopic resection, while enabling circumferential radiofrequency ablation treatment on a non-scarred esophagus. The study findings are reported in their paper entitled Radiofrequency Ablation and Endoscopic Resection in a Single Session for Barrett's Esophagus Containing Early Neoplasia, a Feasibility Study, in the December issue of Endoscopy. Background and study aim. Endoscopic resection with radiofrequency ablation 6 weeks later safely and effectively eradicates Barrett's esophagus with high-grade dysplasia and/or early cancer. After widespread endoscopic resection, related scarring may hamper balloon-based circumferential radiofrequency ablation. However, circumferential radiofrequency ablation immediately followed by endoscopic resection in the same session might avoid the impact of scarring and reduce laceration and stenosis risk. We aimed to assess the feasibility of such an approach. Patients and methods. Patients with Barrett's esophagus greater than 3 cm in size and greater than 1 visible lesion, high-grade dysplasia and/or early cancer were included. Visible lesions were marked with cautery, and circumferential radiofrequency ablation was delivered using 2 applications and a cleaning step followed by resection of the delineated area. Outcome measures were surface regression of Barrett's esophagus at 3 months, need for subsequent circumferential radioablation, complications, and quality of resection specimens. Results. 24 patients, 20 men, 4 women, mean age 68 years, standard deviation 12, Barrett's esophagus median length C6M8, underwent single session circumferential radiofrequency ablation along with endoscopic resection, providing a median of 4 interquartile range 2 to 6 resection specimens, early cancer 18 patients, high-grade dysplasia 6. Complications included 1 perforation, 4 bleedings, and 5 stenosis. All were managed endoscopically. Specimens allowed assessment of neoplasia depth, differentiation, and lymphatic or vascular invasion. Median Barrett's esophagus surface regression at 3 months was 95%. No patient required a second circumferential radiofrequency ablation procedure, and 40% required repeat endoscopic resection for visible lesions. Complete response for neoplasia was achieved in 100% and complete response for intestinal metaplasia in 95%. Conclusions. Circumferential radiofrequency ablation followed by endoscopic resection in the same session is feasible but technically demanding and associated with a substantial rate of complications and a repeat endoscopic resection. This approach should be reserved for selected cases in expert centers, with endoscopic resection and radiofrequency ablation 6 to 8 weeks later remaining the standard combined approach.